Hello again. We're going to start with bipolar, hopefully get through this today, and also I'll have another one for schizophrenia. So let's go ahead and get started. We're going to talk about bipolar disorder, and bipolar disorder is used to be called manic depression, and it's kind of easy if you think about it. It's called bipolar 1 and bipolar 2 now, bipolar 1 being manic as the main presentation, and bipolar 2 being depression as the main presentation. The necessity to be considered bipolar versus unipolar depression or major depressive disorder is the presence of mania. So make sure you keep those separated. Again, it's a neurobiological thing. Serotonin has some parts to play in it, as does dopamine. They think maybe genetics have some part to play in it. Societal norms have some part to play in it. They're not really sure, but they do know, again, the medications work. So they do know that bipolars have larger ventricles. They have increases in norepinephrine, serotonin, which cause problems, maintaining stable mood. And so then we get our little hamster on the wheel and bipolar disease. Bipolar 1 mania is more present in males, and 2 more present in females. Obviously, that seems logical. It says there's about 3% of the population. I think it's more than that, but it starts when you're 18 to 30. There is a criteria for bipolar 1. There's criteria for bipolar 2, but the main differentiating criteria is the presence of mania, so we'll talk about this. Difficulty concentrating, insomnia, grandiosity, flight of ideas, pressured speech, thoughtlessness, without regard to other people. Characteristics, it's on a continuum. They can be hypomanic up to manic. Hypomanic would be equivalent to someone with maybe 400 milligrams of caffeine in their system, so roughly 7 cups of coffee. That'd be hypomanic. And then a full-blown mania, which is a big problem because they can actually not eat, not sleep, and have cardiovascular collapse just because of physical exhaustion. So the thought processes, they have very poor judgment, impulsivity, lots of hyperactive behaviors, highly distractible. You'll know a manic when you see them. They're wearing several dark neck scarves, maybe possibly 3 different shirts, lots of necklaces and rings and polish and makeup, and they're really, really bright individuals. Got to make sure they're safe, because they can commit suicide. Remember, suicidality goes with every psychopathy. Bipolar is not immune, so we have to make sure that they don't have any plans. We want to look at their affect, their thoughts, behaviors, suicidality, substance abuse. And then I put a nice little picture in there for you to see the bipolar, and to live with 2 extremes or split extremes, I couldn't imagine. You have to remember that bipolars, they're ill. And as a result of this illness, this neurotransmitter alteration, that they're very manipulative people. They are very black and white, so they're split personalities. They'll try to play one nurse off another nurse to get some sort of satisfaction because they're irritable. I imagine I would be too. So we have to set limits on them. Set limits, set boundaries, and we have to help family members with limits and boundaries. We want to make sure that they are capable of doing that. Sometimes, the drug of choice for bipolar is lithium. And lithium's nice. It has a very narrow therapeutic index, so it can get toxic rather easy. I would suggest for the exam that you know the signs and symptoms of toxicity, you know the levels for lithium, because I will ask you those. But until it kicks in, it takes about 2 weeks. We want to treat them with antipsychotics, antidepressants, depressants, and lots of support if we can. Sleep, we want to maintain their sleep patterns, their sleep hygiene. We want to make sure that they don't drink coffee, reduce stimuli, make sure they're eating finger foods are best. I always tell people manics are kind of like toddlers. You give them something that's high protein, low fat, that they can carry around as portable. Remind them to eat, remind them to go to the bathroom. It's just like your young people, because if they don't, they'll get to playing and they'll forget to go to the bathroom, and next thing you know, they're constipated. It's the same thing with manics. So you have to remind them to go to the bathroom, to drink lots of water, to drink juices, do what you can to get food into them as they're moving around. Let's see. Planning. When they come to you, when you meet them for the first time, their presentation is going to be very labile. They're going to be extremely manic. So make sure they're safe. It's one of the first things we do. Safe from themselves. We get the medication begun. It takes a couple weeks, so we start the antipsychotics for the behaviors to continue that. Continuing on it, they're going to start feeling better. They're going to start feeling more even. This is really a troublesome time because when people feel better, they think that they don't need the meds anymore. So you're going to have to keep them on the medication for as long as you can and prevent them from not relapsing or giving up their medication. You need to be firm and calm in your approach. You tell them, you remind them, we've talked about this behavior. People don't like when you come up and are in close proximity to their face. They don't like when you are yelling at them or talking loudly with them. We've talked about this, and make sure you have talked about it. I don't know what you need right now. You need to slow down and tell me what I can do for you first. Limit their clothing selection. Limit their access to clothes and makeup, because they will just they'll put everything on. You might have to supervise the bathing. Not that they'll hurt themselves, but they may be more likely to overly wash, overly scrub. And that's not a good thing, because it can exfoliate the skin and cause all sorts of damage. Low levels of stimuli. Sometimes you need seclusion with them. It just depends on how bad they are until the lithium kicks in. And like I said, I'm not going to tell you a whole lot about lithium. I'm going to let you research it on your own. It's one of the oldest drugs. It came out in the 1950s. It is a good mood stabilizer by stabilizing the sodium transport. Now, when you're dealing with sodium, you're dealing with water. So there's a lot to be said about lithium salts, and they are salts. The interventions don't really go with watching their fluid intake, watching their salt intake, no. Weights, no, not really, because it's based on a stable, a homeostasis of the person. So you don't have to necessarily dose adjust or anything like that, depending on fluid, which is nice about it. I did put in there the levels for you, 0.4 to 1.3. I did give you a page out of the book. I can't tell you which slide it is, but it gives you the toxicity, it gives you the therapeutic levels, what you need to know, what they look like. Excuse me. What they look like, and what you have to do with that. Usually you have to stop it. We don't want to give lithium for anything that's going to increase the metabolism. So we don't want to give it for cardiovascular disease. We don't want to give it for thyroid. Lithium's really horrible on the kidneys. After 30 years, you pretty much need dialysis. So any kind of renal disease, pregnancy, breastfeeding. And as you're talking about psych drugs in general, let's address this whole elephant in the room with pregnancy. Some doctors leave them on their medications, some do not. It just depends on the doctor. Paxil is supposed to cause some cardiovascular malformations. It's an SSRI, so does that mean that all of them cause cardiovascular malformations? Well, I know of one doctor in town here who will continue with an SSRI during pregnancy because her experience has shown that no, it's not necessarily a class effect. She'll use Prozac and doesn't have anything to it related to that. But if they become pregnant, we can take them off lithium if we need to, and we can use the anti-epileptic drugs or the anti-seizure drugs, Depakote, Lamictal, Trileptal. What else I got in there? Tegretol, yep. Topamax, yeah. They work with sodium also, but mainly at the nerve site, so they are decreasing stimulation. It's good. They do work. Sometimes in really bad mania, you'll see not only lithium, but also an anti-epileptics are going after it from two angles. But we need to treat them with something. If they're not pregnant, we're going to go, like I said, with further behaviors. We're going to use antipsychotics until the lithium kicks in. It's going to slow down their movements. It's going to slow down their speech. It's going to basically put them back in line, not normal, but back in line with being able to control themselves, because when they're really out of control, they're really out of control. We can use some anxiolytics, Klonopin, Ativan, or the antipsychotic Zyprexa and Seroquel. I give you a laundry list there. Zyprexa is nice, Seroquel is nice, but remember, anytime you pick up an antipsychotic, regardless of what you're going to use it for, you're going to have extrapyramidal side effects. Depending on the class of the drug, if it's a first generation or second generation, and the severity of the EPS can be detrimental. So just kind of be aware when you're having a manic patient if they're on lithium and anxiolytic and an antipsychotic. Either number one, the antipsychotic needs to be there because the behaviors are not controlled with the lithium and the anxiolytic or anti-epileptic, or someone forgot to take it off. So that could be a discussion you'd have with your doctor, asking. And I know a lot of psychiatrists, they'd love to teach about the meds. So hang in there with it. I think that's it on bipolar. I hope it didn't sound bipolar while I was giving you that basic information. But that's a big differentiation. In depression, unipolar depression, you don't have any manic or hypomanic episodes, whereas in bipolar, you do have depressive episodes even when you're manic. So one is a single episode, the other one is two. All right, let's end this one so I know it's over.